to our grand rounds today. I hope you're all doing well during these challenging times. And thank you for joining us today for this very important and very timely grand rounds presentation. First, I want to remind everyone of upcoming World Day events, particularly our New York State World AIDS Day, End of the Epidemic ETE Summit. I actually just placed into the chat information about that with the link for registration. This is the World AIDS Day and ETE Summit events held virtually on December 1st through 3rd in 2 weeks. And this year's theme is Story of Ending the Epidemic, Past, Present, and Future. The event will feature a wide variety of presentations that will showcase the ETE efforts across New York State. And again, in the chat, you see this information and a link to that. Also, during that week here at the HIV Center on Thursday, December 3rd, at this very same time, we will have our Grand Rounds presentation by J.D. Smith from University of Utah School of Medicine. And he's talking on implementation science in HIV, where we are now and where is the field going. And I will give you one more heads up in terms of a Grand Rounds event in January. We're privileged to have, most of you know, I think him very well, Charles King from New York and Housing Works and Ending the Epidemic Task Force. And he will be talking on January 21st on homelessness and harm reduction from HIV through COVID. And as you can see, we're kind of having a theme of the intersection of HIV and COVID. And so now to move on to today's event, I have the honor and privilege of introducing today's guest. And Dr. Taráz Samandarí is medical officer and epidemiologist in the Division of HIV/AIDS Prevention at CDC, and he's working in Kenya. Previously, he served on this DHAP, which is the Division of HIV/AIDS Prevention in CDC. He served in their epidemiology branch chief in Atlanta, in which he led the work of HIV researchers located in 3 continents to design, develop, and conduct epidemiological, clinical, and implementation studies to improve HIV care and prevention in a variety of populations, including among US minorities. He's a graduate of the University of Colorado Health Sciences Center and attended Vanderbilt University and the University of Maryland at Baltimore for his specialty and subspecialty trainings. And importantly, Dr. Samandarí is the program director for HIV research at CDC's Kisumu Clinical Research Site. I've been to that site. It's a really wonderful site located in Kisumu, Western Kenya. The site is engaged in several AIDS network trials, including many of you are aware of the new cabotegravir, long-acting cabotegravir trial for the prevention of HIV in African women, and USAID sponsored trials of phase 2 dual-purpose vaginal ring for the prevention of HIV in pregnancy. And notably, and particularly relevant to today's topic, when COVID-19 reached the shores of Kenya in early 2020, he served as CDC's Kenya's COVID-19 response coordinator for 4 months through the initial peak and decline of the pandemic in this East African country. So you can see why he's well positioned to speak with us today about responding to Kenya's COVID-19 pandemic, whilst preserving progress against HIV. Both of these important on all of our minds. Welcome, Dr. Samandarí. I turn it over to you now.
Thank you very much, Bob. It's my privilege to speak to you all this chilly morning in New York. I'm calling you from the beautiful environs of Nairobi, which is in the highlands of Kenya. And the weather here is still quite pleasant. It's going to get a little warm in the next couple months. And thank you for that very generous introduction. I'd also really like to thank Theo Sandfort for having reached out to me to make this presentation. He's been a wonderful collaborator for our site, and to this day continues to help mentor some of our scientists in Kisumu. And we had a great project working on MSM, men who have sex with men in Western Kenya. Really groundbreaking work for us, so we appreciate his guidance and work with HPTN. So let me see if I can share my screen, my slides. Can you see the slides, and is it in slide share mode?
Yes, looks good.
Okay, great. All right. So I've timed this kind of around 45 minutes. That's what I'm going to shoot for. Hopefully it won't go over, and I'll do my best and hope this will be informative and thought-provoking, and I'd really welcome questions and thoughts from the audience.
And excuse me for interrupting. For what I forgot to mention, to remind everyone, I think people know this, to please be on mute during the presentation, but also place your questions in the chat at any point during the presentation, and or you can place your name there and then unmute yourself and ask your question. And as you just heard, there will be time at the end for us to have a Q&A and discussion. So thank you for that.
Great. Okay, so the findings and conclusions of my presentation are just mine and don't represent the views of CDC, and I have no conflicts of interest to disclose. So Kenya is a lower middle income country in East Africa. It's a population of about 48 million. Nairobi, the capital city, which is situated in the Central Highlands, and can you see my mouse moving, Bob?
Yes, we can. Yes.
Okay, great. Nairobi's here in the Highlands, and it's one of the more densely populated parts of the country, the most densely populated part of the country, which is relevant to this discussion. But also Western Kenya, which is where our work is. And here is Kisumu, where our KEMRI CDC site is located and where we conducted the HPTN 084 and 075 studies was conducted, is also quite densely populated. The third major area of population concentration is on the coast near the port city of Mombasa. The area of the country is about twice the size of Nevada. 36% of the population is estimated to live below the poverty line, and unemployment is a chronic issue. The population is primarily engaged in agricultural work, followed by services. And you can see the important industries of tea, coffee, flowers, and tourism. Reasons we and many others were concerned about the impact of COVID-19 in Kenya and many other countries in sub-Saharan Africa are the large number of HIV-infected individuals. In fact, Kenya is like in the top, it's like the country with the fifth largest number of persons living with HIV, almost just over 1.5 million. The TB incidence is high here as well. It remains in the top 20 according to the World Health Organization. And of course, there are hundreds of thousands of former TB patients, many of whom suffer from chronic pulmonary disease and sequelae of their TB. Hypertension is not uncommon, and 8% were diagnosed as having severe hypertension in a survey done by the government of non-communicable diseases back in 2015. 3% had impaired fasting glycemia. Diabetes is certainly a growing problem here, as is obesity and overweight. The city of Nairobi and a number of other large cities have large informal settlements. Surveys done of Nairobi's informal settlements have shown 26% in one case and 46% in another of children who are stunted in their growth. And of course, being a middle-income country, or a low to middle-income country, the health infrastructure is weak. So my presentation will follow these 7 sections. The first one is just to review the epidemiology, or share with you the epidemiology of what's been happening in Kenya. Number 2 are the mitigation efforts put into place. 3 is some perspectives from the citizens based on surveys that have been conducted. Fourthly, healthcare resources to try to address the COVID pandemic, and then the impact of the pandemic on healthcare so far in Kenya. And 6th, preserving the progress against HIV, and some concluding thoughts. As of today, the report for yesterday, the 18th of November, the national government reported 72,686 cases since the outbreak began. First case having been reported on the 12th of March, and 1,313 deaths. You can see there was a peak in July and early August, and then followed by a trough, and then another peak, and we are still climbing as of this week. Some of the smart epidemiologists we have on our staff at CDC Kenya were able to pull together these beautiful graphics of case rates by county. So this is normalized by the population of each county, and these are rates by month, not cumulatively. You can see how Nairobi and Mombasa were initial foci of the detection of cases in Kenya. This gradually spread. In the months of May, this intensified in both Nairobi and Mombasa. June intensified even further. Then July and August hit our first peak. And you can see Nairobi had 192.9 cases per 100,000 population. And Mombasa at that point was declining somewhat and then declined further. But you also see in the month of August that this now has spread most definitely outwards to the outlying counties. And this coincided with the mitigation plans. Nairobi then declined in the month of September. But then again, everything came to a crashing increase in the month of October, which has continued to steepen at this time, Mombasa too. So testing capacity is a key aspect of trying to understand what's going on with this epidemic. So what happened here in the months of August and September, when we had this decline in cases reported to the Emergency Operations Center? Well, they have now put together this great graphic which shows you testing rates per 1,000 population. And you can see here in mid-September, we had a decline of about 50% from the testing rate that we had in August. So certainly we were kind of flying blind at this point during the epidemic in Kenya. Currently, we are testing about 6,000 to 7,000 a day. You should bear in mind that there are tremendous global pressures on the commodities related to testing, not only those reagents that go into the machines, but also PPE for the lab staff. We had a point at which the lab staff did not have enough N95 masks to carry out their work, and even gloves were of concern. If you plot GDP versus tests per 1,000 population, you can see Kenya is definitely on the low side amongst many of the countries of the world. Many of the countries in sub-Saharan Africa are in this range. Kenya is relatively doing well compared to many others, though. What about the percentage positivity? This graph here in the bar chart shows you the number of tests done in blue and in red, the positives. But the black circles represent percentage positive. So even though we had that lull here, or a decline in the months of August and September, the percentage positive was actually low. And I tend to believe that we really had a decline in a sense, because our deaths were not particularly high, hospitalization rates were not particularly high, and it seemed as though it had gone away, and some people even thought we'd flattened the curve. But then it came roaring back, and now we are at 16% positive among the tests being done, and that's where we still are today. The big question is, who is being tested? This really hasn't been analyzed adequately. Since the beginning of the outbreak here in Kenya, what we've observed is basically 90% or more have report no symptoms. And this doesn't bear out with what we hear about reports of properly conducted cohorts, where we see, such as in the article by Oren et al., of about 40 to 45% being asymptomatic. It could be that because of Kenya's youthful population, there are fewer symptoms. Could be that many people who work have been required to have acquired negative certificates. Maybe that's why this is negative. Many are negative, have no symptoms. Prisoners and healthcare workers get screened, as do truck drivers. There was an outbreak in some of the government departments, and so a whole bunch of government workers were required to be tested, etc. Some of these could have been pre-symptomatic persons, and also people may have minimized their symptoms. And we certainly have had anecdotes of people saying at the triage point, I have no symptoms, but once they get to see the doctor, they describe their symptoms. The spread, I believe, has been heterogeneous in this population in Kenya. Evidence for this comes from studies done by Kemri Wellcome Trust here in Kenya, having developed their own serologic assay. And looking at samples up to August of this year, they found 13.3% of the population, by their estimate, and this was adjusted for a number of factors, were seropositive. If you compare this with the actual number of cases reported back then at the same date in August, it suggests that this is the seropositivity suggests that there are 275 times more people infected than what was being reported by the national authorities. That means about 6.4 million infections. To put this into context, in New York, what you all have observed is, again, in looking at blood donors, in the month of by the month of July, there were 11.6% blood donor seropositivity. And compared to the cases reported by New York City's public health department, it suggests that this was almost fivefold higher than what they were accounting, meaning 1 million New Yorkers have been infected at this point in July. Again, could SARS-CoV be far more widespread in Kenya? The same team also looked at women attending an antenatal clinic at Kenyatta National Hospital here in Nairobi, and almost half were seropositive. And these are women who are primarily drawn from the densely populated informal settlement of Kibera in the heart of Nairobi. This, I think, is probably true. We haven't conducted a proper survey of the informal settlements yet, but CDC plans to do so. But compare this to Mumbai slums, where 54% were found to be positive in randomly selected households, and in contrast it with the non-slums, where 16% of people were found to be seropositive. This was from a report earlier this year. Healthcare workers are, of course, here disproportionately affected. We've had 2,392 cases among healthcare workers, and 31 of whom have died. The case rate among healthcare workers is about 15 times higher than the general population. And you can see we had a peak back in June and July, and then another peak now. Antibody tests done on healthcare workers at Kenyatta National Hospital showed a 41% seropositivity, and it seemed that the lower the cadre of the healthcare worker, such as orderlies, the higher the rate of seropositivity. Case fatality rate, though, of healthcare workers remains the same as the general population, between 1% and 2%. So we do not want to lose our healthcare workers in the midst of this pandemic and all the other healthcare issues we struggle with here in Kenya. Prisoners have been affected as well. One of my CDC colleagues has referred to prisons as being cruise ships on land. We have had thousands of cases among prisoners, including prison staff, and the movement of prisoners in and out of remand and then into court, and then prison staff moving in and out of work and the community. You can obviously see there's a tremendous opportunity for amplification of COVID-19 with prisons. Truck drivers have been a source of attention from the very beginning of the pandemic, particularly with concern about truck drivers bringing the disease into the country, but rates have been relatively low. I'll talk more about truck drivers later on. Now, how far will COVID-19 spread in Kenya? Well, we don't know, but there are smart people sitting around who have good statistical skills, and there have been several efforts at this. The team at Kemri Wellcome Trust has proposed that over the next 10 months, we may see as many as 7.2 million infections. This is different from cases because we're not talking about cases reported to the national government, but infections in the community. For them, they think that the peak is already past us in July and August, and they use their serological data to inform their model. Another team of a consortium of several different university statisticians thinks the peak will come in January and February, and a total of only 1 million cases. Yet a third team with University Nairobi suggests that just over a quarter of a million cases in all over the next 12 months. So as you can see, projections vary widely. And in fact, a couple of articles that I've pulled up here, this is one from CDDEP, which is based in Washington, DC, and a collaboration with Indian scientific institutions, suggests that in Kenya, we will experience, or we would have experienced by now, November, a peak of 1 million infections per day and 20,000 severe infections per day in November with a hard lockdown. we are not seeing this right now. An earlier prognostication by a team from WHO Afro suggested that Kenya would see over a 1-year period 6 million infections, 5,200 of which would be severe, and 3,300 deaths. So what happens to a cohort of Kenyans once they're infected? Is it the same as what we see elsewhere? Well, thanks to WHO's FFX protocol, we were able to participate in this. And in Western Kenya, in Kisumu, again, this is where we are based, we were able to participate in a study that looked at 107 community cases. 70% of them had no symptoms. The hospitalization rate was 10%, and there was 1 death. Yes, this is a small sample size, but this 1% is actually quite similar to what we're seeing overall for Kenya and in many other parts of the world. And this individual indeed had chronic lung disease and asthma. Overall, for those diagnosed, 22% were overweight, 12% are persons living with HIV, and 8% were diabetic. And all of these are reflective of the general population. In another survey now done, study now done of almost 800 COVID-19 patients from 6 hospitals all around Kenya between the months of March and September, they found 58% were symptomatic. And keep in mind that at this point, early in the pandemic, even asymptomatic individuals were being admitted to the hospital. But over here, they found overall comorbidities were found in 43% of these hospitalized individuals. 11% were admitted to the intensive care unit, 7% were mechanically ventilated, and 14% died. Risk factors for death were age over 60, comorbidities, twofold more than those who had no comorbidity, and male sex, 1.276 hazard ratio compared with females. Let's scrutinize COVID-19 deaths in Kenya. So comorbidities among those who died included hypertension, 36%, diabetes, 26%, heart disease, 6%. Interestingly, I plotted deaths in the United States by age group using data from this visualization website from CDC. And the proportions of people who die by the same age categories that we've had here in Kenya actually are quite remarkably similar. Perhaps a bit of a difference here in the 50 to 59-year-olds, but it really are the people over the age of 60 that are in the highest risk category. Looking around the world, case fatality rate of persons living in Kenya, as I've mentioned before, is the CFR here in red is 1.8%. In the US, it's 2.5%. Mexico is at almost whopping 10%. India at 1.5%. This could be attributed to the population pyramids in these 3 countries, Kenya, Mexico, and the United States. If you just use that 60-year-old cutoff, you can see why Kenya's had a relatively low proportion of deaths here. We've had a death rate of 2 per 100,000 population, Mexico 77, and the United States 72. Excuse me. What about excess deaths? We know from the Ebola epidemic of West Africa, more persons died from non-Ebola virus disease than from Ebola virus disease due to the disruptions in the healthcare system. Unfortunately, we do not have an answer to this here in Kenya. But below, you can see what has been shared by South Africa's government. And you can see the black peak is what's over the expected forecast of deaths, well over the 95% prediction for South Africa. We might see the same here in Kenya, but the jury is still out. All right, let's now turn to mitigation efforts. Excuse me. So Kenya was quick to put together a National Emergency Response Committee. This was established in February, at the end of February this year. It also established a national COVID-19 task force at which partners were invited, and it's on this task force that myself and other members of the CDC team were involved, the World Health Organization, the WHO representative prominently participated in the task force meeting as well. And so these had somewhat irregular meetings, but useful discussions. CDC assisted not only the National Emergency Operations Center, and this was actually from before when we were getting ready for Ebola, because the border with Congo is just like a 6-hour truck drive away from the border of Kenya. The National EOC was well established and well positioned to be pulled together and try and respond, but many county level EOCs still needed help. And so our CDC team did help 17 counties, among them are the ones here. And here are these yellow, green, and red squares represent how ready they are for various things. So for example, in the case of the preparation of the EOC, the Emergency Operations Center, Nairobi's is green. They have an operational Emergency Operations Center, is well equipped, and they have staff and they have communications. But Nakuru, where we've actually had a pretty rough upsurge in the last 2 months, their EOC has not been stood up, and the others are all partially getting their act together, etc. We also had our statisticians prepare weekly case rates per 100,000 population by county to help the counties see whether their epidemic was going up or down. And now it's been gratifying to see that the National EOC is also replicating this kind of information to give a week-by-week data to the counties to plan and to assess their interventions. I'd like to spend a little time on these mitigation efforts by the this chart about mitigation efforts by the government of Kenya. As I mentioned, the National ERC was established here late in February. In early March, flights from China and Italy were suspended, and a few days later, the first case in Kenya was reported on the 12th of March. Subsequently, hotels, supermarkets, mass gatherings were all restricted, schools were closed. Then the border with Uganda was closed, international flights were suspended. Then when they realized that the epidemic was particularly intense in Nairobi and Mombasa, those two cities were put under a lockdown, which wasn't a full lockdown, but the curfew was pretty rigorous in that basically after dusk, everyone had to be home. Mask wearing was mandated. But you were still allowed to travel relatively freely around the city, but only within the city and not allowed out of the city. And this lockdown for particularly Nairobi and Mombasa continued until early July. The border with Tanzania was closed except for cargo. Somalia's border had been pretty tight anyway due to terrorism issues, but that was tightened even further. But then finally, when July came around, these lockdowns were lifted, and it was, I think, perhaps mostly out of a sense of being exhausted with the lockdowns at that point. Places of worship were allowed to be reopened, but with limitations. Domestic flights were then resumed, and then at the peak, the first peak we had, international flights were resumed as well. Subsequently, hotels were allowed to now liberally sell alcohol, restaurants were open longer, and then schools became partially reopened, and in fact hadn't fully opened at this point. And then it just took off again. And at this point, what we have put in place, the president of Kenya announced that political rallies should be suspended, and these had unfortunately been going on during this period before, but they also increased the national curfew somewhat by an hour on either end, and bars and restaurants' hours were also reduced. So there we are. Google Mobility has freely provided data around the world, and it's interesting to watch the trends. We definitely had a steep decline between right after the curfews and the restrictions were announced in early March. And you can see which sectors of the society have reduced mobility. So this has been an interesting and useful trend to follow, and is very informative for those who are modeling at this point. Truck drivers, who are initially of great interest, have had an interesting tale to tell. There are 22 points of entry, but not all of them are open, and not all of them have public health authorities screening individuals. The one that's of greatest economic interest is of one with the at the Kenya-Uganda border. The regulations were from both countries that drivers entering and leaving the country had to have a negative test in order to cross. But obviously, with the shortages of reagents at the lab, sometimes these truck drivers were really stuck, and they were stuck for days, if not at times for more than a week, and sometimes 2 weeks. In one case, you can see a news report of the truck drivers being stuck here in a queue 19 miles long. But an important aspect to this, though, is it does require organization from both countries and coordination between countries. It requires quick turnarounds on lab testing. It also requires health informatics to be strengthened. At one point, we started hearing about, and no surprise for here in Kenya, fake certificates being issued in the name of CDC labs and other labs. But that came under control using a QR code and using strong health informatics. Also, mobile phone technology was important to apply. Hotels were designated for drivers at the crossing points, but many of these hotels were too expensive for the drivers. And then the HIV concern came up with commercial sex workers who ply their trade at these border towns, and the concern with transmission of STIs as well as HIV. This seemed to have been, it hit the news in Zambia. The Ministry of Health has been very active in providing guidance. They gave interim guidance on infection prevention and control, IPC as we call it, and case management. They issued recommendations for how to take care of people at home. This was particularly important once we realized the isolation facilities and quarantine facilities the government had prepared were just far too few for the population that was being infected, etc. And then targeted testing strategy was also announced, but not really promulgated through action subsequently. Contact tracing has been really difficult to do. Over here, what you see is in red are cases pending contact tracing, and this is shown by all 47 counties of Kenya. And overall, what you can see, about half do not have contacts, or their contacts were pending. And at this point in the report, more than 20,000 people were in that category. Overall, the ratio of cases to contacts is one case. For every case, there's less than one contact that is ultimately listed. So it's definitely remains a big challenge for Kenya. Risk communication and community engagement is a key part of how to try to counter the epidemic. On a daily basis, the Cabinet Secretary provides updates to the nation, regularly reminds everyone to wear masks, wash their hands, and socially distance. There is a Komesha Corona media campaign that is ongoing. At times, the police arrest people for not wearing masks. This sometimes really aggravates the situation in that people get thrown into jail with other people and in a congested environment, and then get sent out back to the community. And to be honest, there have been really limited efforts to engage communities at the grassroots level and convince them about the reality of this pandemic. USAID in particular has been helpful in promoting communications and radio interviews and TV spots to inform people, educate people about coronavirus. The Kenya government has really tried to support the population, given the drop in the GDP, increase in public debt and unemployment, a decline in the exchange rate for the Kenya shilling. 4.5 million people were projected back in, I think it was earlier in July, to experience severe food insecurity. Fortunately, this has not materialized to be as bad, partly because we've had this irregular climate change associated rainfall, which has given us 2 crops instead of 1 in some parts of Kenya. The government gave an economic stimulus in March and then in May, and based on comments I'm receiving from colleagues and friends in Kenya, this has really helped people get pulled through the decline in the ability to work. Kenya does have an overview of a response strategy, but it's really limited to this diagram that you see here, which is certainly an excellent strategy and a plan to go ahead, but it does need to get elaborated further. And then what we had, very unfortunately, the revelation that, quote, much of 2 billion in money and medical equipment that had been donated by the World Bank, by the International Monetary Fund, or by Jack Ma Foundation, which is a Chinese foundation, have quote unquote gone missing. So this, you can see this gentleman over here protesting, which is saying, and it's on a shirt, it says, #arrest COVID-19 thieves. In August 31st, the president of Kenya directed KEMSA, which was the agency that was implicated with much of the disappearance or the high cost of the commodities being purchased through it. After these allegations, he ordered that that there be a publication and transparent notification of what all these tenders were that the money had gone through. So let's talk a little bit about what the citizens have said. So the word for citizen in Kiswahili is wananchi. So in Kenya, we have, as I mentioned before, many people who live in the informal settlements. This aerial picture on the left shows you some of the informal settlements housed right next to some relatively wealthy suburbs. Half of the nation's population lives below the poverty line, as I've mentioned before. Those who live in these informal settlements have to share toilets and bathrooms. Quite often a family of 4 or 5 live in a 4 by 4 meter dwelling in these places. They don't have refrigeration, they don't have the capacity to store food or water, and really have to strive to work every day in order to have an income. Luckily, most of these people living here are relatively young, so that's the one thing that is on their side. The survey funded by Kantar, a national survey that's supposed to be representative of the country, shows that many people are very much aware how COVID-19 is spread. They say they do wash their hands and they use sanitizer, they do wear masks, more than 90%, but many people, 15 to 32% in the informal settlements, say they cannot afford or do not have access to soap or water in their homes. Social distancing is very difficult to do, but many of them do support what the government has recommended. Mask wearing, I've already mentioned this. Ability to self-quarantine, 87% are unable to stay home for 2 weeks. Only 28% have a separate room. This is why government-sponsored isolation or quarantine facilities would be important. More than half said they skipped a meal or more in the past week, and anxiety is definitely high, with many worried about their income, many worried about the education of the children, and certainly many kids have lost a whole year's worth of education. In another survey, 42% reported lack of infrastructure, running water and washrooms. 62% actually said they will not seek health services if advised. Many because it's too expensive. There's quite often still a copay, even for quote unquote free government service. Many also have problems with having to travel too far in order to seek healthcare services, and others are yet concerned about becoming infected with COVID-19 if they went to a health care facility. Corona is real, but we also suffer with fake news here, as we do in the United States. And you can see many of the thoughts and conspiracy ideas that are circulated among people that have been shared in some of these surveys. Let's look at some of the health resources that Kenya has. Here's a photograph of the beautiful Mount Kenya, more than 14,000 feet high. Kenya has 0.15 doctors for every 1,000 people in its population. By comparison, the US has 2.6, which is 17 times more. We have 1.35 nurses per 1,000 population, and that's again more than tenfold below the US's rate. 1.4 hospitals per 1,000 population. Maternal mortality is relatively high, and although it has been improving in recent years, and you can see life expectancy for men and women. Healthcare capacity to respond to COVID-19 in particular, we have about 126,000 healthcare workers, 157,000 beds for quarantine facilities where suspects and contacts could be isolated, isolation facilities for people who have infections, 11,000. We don't know about PPE quantities, but interestingly, the person in charge of procuring PPE said this is a bottomless pit, and she's right. Hospital beds for people who are severely sick, around maybe 7,000 or 8,000. ICU beds with ventilators, 300. The US government recently donated 200, including with that package came a training for staff, which is, I think, a very generous contribution. However, more than ICU beds, we will need CPAP devices, continuous positive airway pressure devices. We need oximeters to monitor how how well people are oxygenating. We also desperately need to improve on oxygen production capacity. This is the current capacity, about 500 million liters each month. We do have dexamethasone in the country. It's standard of care. Remdesivir now, from what I'm hearing from my colleagues who are well placed to know, say there is plenty of remdesivir, but this is of course for paying customers, not for the average Wananchi. If you want to hospitalize someone, on average, the CDC and WHO say a stay of 14 days is needed. And so we use these statistics for planning purposes. Oxygen needs, you can see here, which is voluminous. A Kenyan doctor wrote this in a report that came out on Medscape. He said, during my last week working in the COVID-19 ward of a relatively well-resourced referral mission hospital, just 4 coronavirus patients consumed over a quarter of the facility's oxygen capacity. The use of 50 to 70 liters per minute of high flow nasal cannula required to save the sickest patient would exceed the capacity of many hospitals that do possess piped gas, and most, of course, do not. Our modeling team came up with this graphic, which shows the counties of Kenya in a stylized form with squares, so you could put numbers in it. And you can see at the epicenter, Nairobi, they projected that we would need 230 billion liters in 1 month, just for the county of Nairobi when we hit the peak. And this is clearly not enough. We've had, of course, stories of hospitals being overwhelmed and hospitals having case surges around the country. The other chronic problem has been healthcare workers being on strike, some saying they've not been paid for more than 6 months. They've been given, they're telling us in the newspapers, no PPE or faulty PPE. Their health insurance was cut back in July. And in fact, even this week, we've had strikes again by physicians and other healthcare workers. There are glimmerings of hope. Kenya is an industrious country. One factory, actually many, have started to assemble and to manufacture surgical masks and gowns. There's a bright young group called Hewatele that several years ago started producing oxygen at a lower cost than the main producer of oxygen here in Kenya. It can build a new facility for just under $1 million. So what's been the impact of COVID-19 on health in Kenya? Well, there have been some surveys done of essential health services. Outpatient attendance did decline in 2020 as compared to 2019 by almost 20%. The under 5 outpatient department attendance declined by more than half, meaning this is under 5 years of age. So this is the pediatric population. There were overall no declines in skilled deliveries. This was a great concern of what would happen to mothers who are pregnant. So this is good news, although Nairobi itself had a very large decline of 1,700, which might be partly explained by many people in Nairobi having gone up country, as they say, to their native counties. There has unfortunately been documented in several surveys now increase in sexual violence cases, but childhood immunizations have managed to remain stable, thank goodness, for the diphtheria, pertussis, and tetanus 3-dose. Adolescents' pregnancy, although there's been conflicting information in the press, has declined in this period, and there has been a decline in pediatric pneumonia. Cases of TB notification have declined as well, but this is not a good sign. 2,500 fewer cases just in the month of June compared to 2019. And this has consistently been observed in many African countries, suggesting that these people with tuberculosis are not coming forward to be diagnosed and treated. Malaria, similarly, the testing has declined by 50% up to, you can see this was in the weeks of the midsummer. The later months we don't know yet. Decline in cervical cancer screening. Some good news, though. that we do surveillance here. We, that is CDC, support surveillance in influenza in Kenya, and we've seen a tremendous decline in influenza cases. This primarily afflicts young children, so that's been our focus for an immunization pilot that we've begun. And this is not surprising. We've also seen a decline in influenza in the United States, in South Africa, and also in Australia. Those have been published now. Another bit of good news, although it's not a good for the individual who's been diagnosed, is that more people have been coming forward to get tested for diabetes. So we've had a big increase in the number of new diabetes cases diagnosed in the month of August, but also in July. All right, well, let's turn our attention now to HIV. I hope I'm doing all right on time. Bob, can I just get a check from you that I'm going about the right pace?
Yes, you're doing fine. This is great.
Okay.
And
you're still awake, so that's a good sign.
We still have 35 minutes left for our entire time here today, so you're doing good.
Very good. Thank you for your attention. So what's known about HIV and COVID-19? I think all of you are very keenly following the literature and probably more up to date than I am, but I did try to do a brief survey. And over here, I've included just studies where I've seen more than 100 HIV-infected persons included in an analysis. Well, from the US, it seems, comorbidities, more so than HIV, seem to be associated with a higher risk of death for persons living with HIV, in this paper published in AIDS. Similarly, looking at a VA population and 253 HIV positive persons compared with 500 who are not, there was no difference in hospitalization or death among COVID cases. And then finally, this third one, well, the bottom two are also from the US with 286 people living with HIV, and poor outcomes were associated more so with comorbidities in the lower CD4. So not so much with being infected. In San Francisco, again, severe illness was not increased in those who were HIV infected in a cohort of over 4,019 COVID-19 positive individuals. However, in the UK, we did see a hospitalized patient survey. Among these hospitalized COVID patients, 122 were HIV infected out of the 46,000 that were surveyed, and they report a 1.6-fold increase in death for HIV-infected persons, and this seemed to be particularly more severe for those, likely, that is, the hazards were higher for those who were lower than the age of 60, threefold, below the age of 60. The only African study I know of is from South Africa, and this is the Western Cape, where they have a really good infrastructure for patient identification in their system. And they found a 2-fold increase for HIV-infected persons and almost a 3-fold increase for persons who had current TB and 1.5-fold increase for persons with former TB. And this was from a population of over 18,000. The authors thought that they might have a bit of an overestimate on these statistics, and that's based on probable low reporting of other comorbidities such as diabetes and hypertension and heart disease. In Kenya, as I mentioned earlier, it's the nation with the 5th largest number of people living with HIV within its borders. It accounts thus for about 5% of the adult population, much more so in women than men. Twice as many women than men are infected. 92% men here are circumcised, and so that's probably led to some protective effect, less so in Western Kenya, which is where I work. And you can see the map over here on the left. The darker orange represents the counties in Western Kenya that are part of our study area. We see 15 to 20% prevalence of those individuals between the ages of 16 and 64. With regards to the WHO 1990 numbers, Kenya is at 80, 96 and 91, which is actually pretty good. We still need to get better at improving on the diagnosis part. But we still have about 30 to 40,000 new infections every year, and about 4 out of every 100 children become infected from HIV-infected mothers, which means about 2,000 children a year. 28,000 people die of AIDS-related deaths, TB being the leading diagnosable cause, and we have 96,000 TB cases each year, with a 6% mortality, obviously with those HIV infected being much more likely to die. So what I'm going to share next for HIV programmatic information comes from the CDC team here in Kenya, where we provide support, or we support the care indirectly for almost 700,000 persons living with HIV, which is almost half of all persons living with HIV in Kenya. In order to protect staff who are on the front line, they are provided N95 masks, provided gloves with or without face shields. They also wear a gown if they have a COVID-19 suspect. We're trying to go to this model of rational use of PPE. In the future, they intend to add virtual follow-ups with patients. In order to protect patients, we have staggered their visits to the clinic. There is a fast tracking procedure for patients, and also making sure their meds are pre-packaged and ready to go. Outdoor sheltered waiting areas have been extended, and patients coming to the clinic are required to wear masks, sanitize their hands, and of course get their temperatures checked, although the latter has questionable usefulness overall. In April, the government of Kenya importantly halted field activities, and also said that non-essential healthcare visits are discouraged, and then issued guidance to accelerate a process that had actually already been underway for multi-month antiretroviral therapy dispensing. So now we were able to give people 6 months worth of drugs. So let's see how this impacted our programs. Well, HIV testing did decline. March to April, there was a sharp decline of 35%, but that has gradually climbed upward, but it really has not recovered. Partner notification services, which usually involves calling partners of those who are recently diagnosed with HIV, this declined sharply by almost a half, and it also has not made a good recovery. And this is partly also hampered by the inability or what's hampering us in making field visits and home visits to patients and potentially infected persons. Also, because of the decline in testing, initiation on antiretroviral therapy has declined by almost a third, and although linkage to care seems to have hung in there, which is good to see. The dispensing of antiretroviral therapy has fortunately remained stable and continued to climb, so that's good. These are for existing patients and those new ones who are coming in. So this is really a tribute to all the healthcare workers and the commitment of patients here in Kenya. Multi-month dispensing, which is something that, as I'd mentioned, was something being encouraged before the pandemic struck Kenya, has continued to rise. So this is heartening to see. The transition to the TLD regimen, which is a much better regimen than many of the previous generation of antiretrovirals for HIV infected persons, has steadily increased, which is a really good thing. So that is wonderful to see. TLD has proceeded. Prevention of mother-to-child transmission services has been a bit wobbly, as you can see, but overall not doing too badly, which is good. TB preventive therapy, this is provision of 9 months of isoniazid preventive therapy to HIV-infected persons, dropped sharply from March to April, but then seems to have mostly recovered. Monthly TB diagnoses has declined and has not recovered. And this is reflective, this is just for HIV-infected persons, mind you, but this is reflective of what's been happening nationally for all TB programs. Key populations, and for us, we're talking about 200,000 commercial sex workers, about 40,000 men who have sex with men, and about 20,000 injection drug users. The testing rates did drop in April and May, as you can see, but seem to have picked up in June, July, and August, which is good to see. Pre-exposure prophylaxis using Truvada has been introduced in Kenya for a couple of years now. Kenya was involved in some of the big trials that were conducted at directing PrEP towards heterosexual couples here in Kenya, and helped to prove its efficacy in this population. It is ongoing, and its focus has been in Kenya based on national guidelines for discordant couples, key populations, as well as adolescent girls and young women who are at highest risk here of getting infected with HIV. And as you can see, there was a drop in April and in May, but it seems to have picked up, which is good. The active enrollment into DREAMS, and DREAMS, as you may know, is an ambitious project that PEPFAR has promoted in many countries in sub-Saharan Africa, directed at adolescent girls and young women to provide not only HIV prevention education and also PrEP, but also condoms, and in addition, providing them incentives to continue staying in school and to keep their education, avoiding teen pregnancy, and also providing some monetary support as well. Unfortunately, because this is primarily a field-driven activity, recruitment into DREAMS dropped a great deal between March and April. And also the follow-up with regular follow-up with these young women and girls declined in April and in May. But that seems to have picked up somewhat in subsequent months, although you can see new enrollments is still lagging behind. Gender-based violence has sadly increased, and this is now just for our HIV-infected population. Earlier, you saw this represented nationally as a whole, but compared to February in August, you can see an increase by 23% in gender-based violence here in Kenya, in our population. So let me come to my final remarks. I've got a few slides here to share. So to summarize the impact of COVID-19 in Kenya, we've had, as I've mentioned, over 72,000 cases. We actually don't have a good handle on how many of these were severe cases, but we have had over 1,313 COVID-19 deaths, and this is after 251 days of the pandemic having hit the shores of our country. Likely, the epidemic is far more widespread than what's reported, perhaps as many as 100 to 300-fold more infections than the cases that we see reported. Nairobi, the capital city, remains the epicenter of the pandemic, with almost 50% of all cases reported. At this time, as I speak, the spread continues to be intense, with a 16% positivity without really stringent non-pharmaceutical interventions being implemented in the country. There has been, without any question, a disruption in the livelihoods of people, ongoing concerns about food security. We've gotten a little lucky with the extra rainfall that we've had. The weaknesses of the healthcare system have been exposed. Many, but not all, essential health services have been disrupted. But we've had a relatively low number of individuals with severe illness and death, we think. And this is probably attributable largely to the youthful population, but there may be other factors, as I'll mention briefly. The incidence of influenza seems to have really dropped, as well as diarrheal disease in our surveillance sites, and I forgot to add that here in my slides. Childhood pneumonia is down. There's an increase in diagnoses of diabetes, which suggests people are seeking healthcare and when they're concerned. What are some potential ways that we in Kenya could improve the response? Firstly, risk communication, I think, and these are just my personal views, can be improved a great deal. Community engagement can also be improved. Certainly promoting the 3 Ws, convincing people that the disease is real. Can we help the community to identify quarantine facilities and isolation facilities that it is willing and comfortable to use? That's an interesting question. And you may have heard of the idea of green zones to protect the more vulnerable. Could something like that be implemented here in Kenya? So far, the answer seems to be no, but we should engage the community far more to try and rally them to help control the pandemic. Number 2, a clear national strategic plan should be clarified and should be promulgated, should be published. This really hasn't happened and should include the partners that the national government has. On the public health side, we definitely can do a lot better at contact tracing. We should establish and coordinate county-level emergency operations centers. That's happening as we speak, which is good, but much more work is ahead of us. There needs to be continuous and ongoing monitoring and management of IPC at healthcare facilities. There needs to be an increase in testing rates and at least maintaining that 1 per 1,000 population. We're hopeful that the rapid antigen test will aid us here, and it's being introduced, and we're planning some pilot studies of using it here. We should empower the counties to turn that non-pharmaceutical intervention dial up or down as needed. Improve the health information systems. There's a tremendous opportunity to do this now, to do end-to-end ability to see diagnoses in the lab, patients in clinics, patients in hospitals, and even individuals when they end up in the morgue, if they do. We should improve surveillance for infections, improve surveillance for hospitalizations. There's a big push for this right now, and certainly improve surveillance for death. There are plans for that as well. Additional ways to improve the response are to strengthen the clinical care infrastructure. Certainly oxygen production is a huge issue in my view, but not just ventilators, but also high flow nasal cannula, CPAP devices, and oximeters are needed as well to scale. Healthcare providers and lab staff need to be increased. We had stories early on of lab staff sleeping overnight in the labs, running their machines breaking down because they were overloaded, and we really needed replacement and maintenance. Provide personal protective equipment to our healthcare staff and the lab staff, pay them and give them health insurance as well. Ensure continuity of essential healthcare services and make sure this is done safely. Based on some modeling work, and one that I thought was rather well done that was published in the Lancet, it's likely that Kenya will experience, like as many other high burden countries, an increase in HIV, an increase in TB and in malaria, the big three, maybe by 10, 20, and 36% respectively. And I think this may happen because of the decline we've seen diagnosing all three of these big diseases here in Kenya. We should also be ready for distributing SARS-CoV-2 vaccines. It's great to see that Kenya has an excellent research infrastructure. There are at least 2 and I think maybe 3 clinical trials that are going on or about to start here in Kenya of COVID vaccines. And 85% of the population here is willing to receive the vaccine. I think in the US, it's more like 50 or 60% are willing to receive vaccines. Now let's talk a bit about my concluding remarks on HIV prevention and care. I think some indicators look stable, such as ART provision, multi-month dispensing. And actually the supply chain was pretty good for Kenya, partly because of the planned multi-month dispensing before the COVID-19 pandemic hit. Some indicators that have worsened, but then made a recovery were the prevention of mother-child transmission, infant diagnosis, and key population testing. Some that haven't recovered are HIV testing, partner testing, ART initiation, and DREAMS and PrEP as well. Some have worsened and not recovered, such as TB diagnoses. Some have just worsened and not gotten better, and this is gender-based violence, and this is reported just from our persons living with HIV. Some questions that would be interesting and important to answer for us in Kenya and many other parts of the world, I'm sure, indeed in the US as well, which is what are the ultimate programmatic impacts on HIV and TB-HIV and deaths, related deaths here in Kenya as a result of the COVID pandemic. Can we continue and strengthen our field activities safely for both staff as well as persons living with HIV? Hopefully vaccines here will have an important role to protect our healthcare providers. What are the outcomes of cohorts of persons living with HIV? So a lot of studies of this are being planned. We're certainly planning on sero-surveys of HIV-infected persons, and this will be important to continue. And finally, what's the efficacy of various SARS-CoV-2 vaccines in persons living with HIV? That we certainly need to test. And also when persons living with HIV are naturally infected, are they susceptible to reinfection? Are they going to continue to be transmitters, etc.? We dodged a big bullet over here. In 1918, the influenza pandemic had a W-shaped curve, and a lot of people in their most productive and young ages succumbed to the disease. In fact, it's said that in Africa, nearly 2% of the population was estimated to have died within 6 months. This time around, after almost a year almost 12 months now, WHO reports most deaths, 0.6 million, have occurred in the American region of WHO, with Africa at just almost 32,000. To be sure, there have probably been many more deaths, given that we have hardly been testing as far as we need to test here in the African continent. But overall, there is a sense, just given what we've seen in burials, for example, and in the morgue and in the hospitals, that something else is going on. Maybe there are some protective factors, and I'll leave you with this thought. Maybe there is cross-protective antibodies as well as T-cell immunity. In Kenya, we've had a couple of teams do some good studies on coronaviruses before COVID-19 hit. And there have been a number of serologic analyses. Maybe BCG, we've seen this come up in the ecologic analyses in the past, and there's been some more molecular study that suggests that maybe BCG may have had a role. Dengue is now, I think, endemic, although we do see in Africa less morbidity and mortality from dengue as compared to the Americas or in Asia. So this is intriguing, and we've had some serosurveys done in Kenya, which have been informative. And finally, maybe there's genetics involved. So there's been this Neanderthal gene that was published in Nature, which is more prevalent in Europe and in other parts in Asia rather than in Africa. And perhaps that's played a protective role. And in the New England Journal of Medicine, there's been this rather unpronounceable loci of genes that have been associated with more severe disease. So that concludes my talk, Asanteni, which means thank you in Kiswahili. Appreciate your attention.
And thank you, Taráz. That was, thank you for leaving time now for questions. And that was a really wonderful and data-rich presentation, much appreciated. I'm going to turn it over to my colleague, Stephen Sukumaran, our Deputy Director of the Center, to facilitate our discussion.
Thanks, Bob. We have a question from Joanne Mantell. Joanne asks, do you have any data on COVID-19 among male and female sex workers?
Sorry, no, we do not.
Okay. A question from Heino Meyer-Balberg. What is known in Kenya about the percent of long haul cases, that is, those with long-term severe symptoms?
Again, this is we haven't gotten that sophisticated yet. So we're still following that. I think the group that's been following cases the best is at the University of Nairobi. And some colleagues there, I think, will know more about that in the coming months. They've just published, the case of 800 is a good start by that team.
Thanks, Taráz. Bob asks, what are your thoughts about seasonal variation in Kenya and globally? That is, warm versus cold weather and indoor versus outdoor time.
Yeah, the cold, hot weather. Well, seasonality is right now, I think, a difficult thing to say that warm weather is, seems to reduce transmission of COVID-19. The heat issue came up early, and many people had, back then originally speculated that because of quote unquote heat, although not all of Africa is hot, and Africa is a big continent, would protect people here from transmission of the virus. Also, humidity has been raised because aerosols, or rather larger droplets, don't travel as far with higher humidity. But I don't think either of those have really come to bear. I think that, and looking at places like India and Singapore, that you've got Singapore is tropical. The virus travels. Hong Kong is tropical. It is actually well transmitted in tropical areas. I do think that perhaps where it's been helpful having the warmer weather is the openness of the architecture. Many buildings are naturally ventilated. There is not a lot of air conditioning. Windows are generally kept open, doors are open, and it's also easy to set up tents outside. So I think that has probably played a role. But that's just my hunch at this point.
We have two questions from Heino. The first is, are cases of reinfection, that is after initial infection, known, especially among healthcare workers?
Yeah, that's a great question. I've been wondering about that myself. We have to follow cohorts, and but it's not that easy to identify a reinfected person. As you've seen in the literature, the ones that have been published are people that they know what virus it was. I mean, they've got the gene of the first virus and they've got the gene of the second virus as well. So it's really going to be hard to prove. But I'm also very curious about this issue as to whether reinfections are going to be commonplace. And I sure hope we can find out with the cohorts that are being set up. And certainly healthcare workers would be prime candidates to begin with. Thank you for that idea. What was the second part? I'm sorry.
I didn't ask you yet. The second question is, does MSM stigma or HIV stigma in Kenya suppress access of such patients to COVID-19 services?
There definitely is stigma related to HIV. There's definitely stigma related to COVID-19. You can lose friends over both viruses in this country. But what's happened with HIV, which is something we've had much longer, is that there's been less and less stigma over time, which is really good to see. MSM is still very stigmatizing to come out and declare yourself as a gay man or woman. So that remains problematic. I don't know if I captured the whole essence of the question, but I think that people are coming back. I mean, when you drive around, for example, Kisumu or Nairobi or in the coast, people are just doing their regular thing these days. And up to a month ago, before the president made the mandate on the 4th of November that no, everyone's really got to wear a mask, things are getting bad. People were just not wearing masks. If you drive around or speak and walk around the informal settlements, 90% of people had no mask on at all. Close proximity. People were coming back to clinics, and you can see from our data, which is probably some of the best data that can be found at this point, people are coming back to clinics at this point. There is some reluctance, but I do worry that many people are not coming forward to get tested. You did see that in the surveys. There were a couple. There was one I remember that I didn't show because I couldn't find which reference, my reference for it. But at one point, 75% of people said, well, if I have COVID symptoms, I'm not coming for a test. Because if they're positive, that means they're not going to get to work. That means their neighbors are going to stigmatize them. And their neighbor lives in a thin wall across from them if they live in an informal settlement. So it is problematic.
Our next question comes from Teo. Is Kenya ready to distribute vaccines when they become available?
I think that it is going to be ready. It isn't ready now. We haven't had formal discussions on prioritizing, but I think it's clear that everywhere in the world, healthcare workers will be on the front line. The frontline people will be the first to be immunized. But Gavi has been involved. World Health Organization has been thinking and planning, and we've been talking. There's increasing discussion about that, especially now that in the last 2 weeks we've had some fantastic news about the mRNA vaccines. So hopefully that will go well. Overall, the vaccine program here is good. We were having a bit of a problem with a measles outbreak in northern Kenya prior to the COVID-19 pandemic. So that was worrisome that there were some cracks here and there. But generally speaking, the vaccine program is good. So I think that they would do a good job implementing it. But a formal plan needs to be put together at this time.
Justin Knox asks, from your perspective, has the health system strengthening focus of recent HIV funding efforts translated to a stronger COVID response in Kenya than might have happened otherwise?
I do think so. Some of it's indirect. For PEPFAR, and by the way, I don't work for PEPFAR, I'm in a different part of CDC, but these are my close colleagues, and I've tried to learn as much from them as I could. But our PEPFAR colleagues have worked for many years now here in Kenya, and their work indirectly, at least, supports the healthcare infrastructure, particularly outpatient care of HIV-infected persons. Given that they have many comorbidities, the capabilities of the clinics serving this population have actually increased over time, which is good to see. PEPFAR has also sunk in a lot of resources for laboratories here in Kenya. In fact, over the course of this pandemic in Kenya, US government lab-supported facilities have actually conducted 60%, 60, of all tests being done in Kenya. So ministry has been buying reagents and then asking either USAID or CDC labs to run the tests. So we've been a huge ally to support them. What else? There's the lab, there are the clinics. Health informatics has been really important. Being able to, and encouraging the government, number one, to have a unique identifier for health that you can go and, the health information system will know who you are, will pull up your charts. That's been really important and something Kenya has not done so far. But finally, they're at the point of doing that. The president announced that actually on the same November 4th presidential address. So hopefully by December, this will start getting rolled out, and that will really help people access care because it'll give everyone a unique ID. But that will also allow us to link health information systems, and the work having been done by PEPFAR and for HIV has strengthened health informatics in Kenya, and I think that will be well utilized in including all the other diseases. Kenya does use the DHIS2 system, which has been developed, I think, in Norway, if I'm not mistaken, and that is being wed to these other systems. So hopefully in another year from now, it'll be much strengthened.
We have a two-part question from Bill Kroniski. Can you speak to how COVID might be especially disruptive for youth, considering school closings and limited economic opportunity? And do you have thoughts on potential approaches to remediate these negative impacts?
Approaches to mediate it. I'm really not an expert on that. I can just throw out a few things that I know of. But without any question, and in fact, I think my heart and the heart of many in Kenya go with the children. The children have had a whole year of their education disrupted. And although it's been somewhat anecdotal and the information in the news goes back and forth, there have been a lot of girls who've become pregnant as a result of COVID, but that's been a background problem in Kenya all along. So it's unclear that COVID has actually aggravated the problem of young women, girls becoming pregnant. But it certainly remains a concern. Employment is a huge problem for youth here in Kenya. You saw the 40% unemployment rate that we regularly endure in the country. The government has a number of programs, but without a real transformation in how it operates and how business is done in Kenya, it's going to be hard to see how things will get better anytime soon. You saw the slide I had about the disappearance of funding. I mean, that kind of gives you a little bit of a flavor of some of the issues, underlying problems in the country.
Thanks, Taráz. I see no other questions. If anyone has a question, we have time for maybe one more. Otherwise, I'll turn it back to Bob for closing remarks.
Okay. If I can say one more thing, I'd like.
Sure.
I want to wish a happy birthday to one of the members of your audience. It happens to be Dr. Raz Stevenson, who is my sister. She works in Tanzania in Dar es Salaam. So just wishing her a happy birthday. Today's her birthday. Thanks for joining, Raz. And also want to acknowledge my friend and colleague, Tim Wyant from Boston. He's joined the call. He and I were postdocs together in Baltimore some years ago. Thank you, Stephen, for allowing me.
Sure, of course. Happy birthday, Rob.
Stephen, can I ask a question?
Absolutely.
Taráz, this was an amazing presentation, and Bob is going to close soon. But I was wondering, isn't it incredibly hard not to be discouraged by all the things that you're seeing? And of course, you know, the US is in an awful situation too. So it's in a way a strange question to ask. But at the same time, I feel like with all the other things that are going on, it must be so hard to keep up hope.
Yeah, I think that it's, we all are, all of us in, you all, we in the healthcare world are really experiencing a tremendous strain. We've had colleagues here get infected with the coronavirus, and as it's increased in Kenya, we've had more colleagues infected. We've had, as I've mentioned, doctors, as we know, dying, one who was in a very key position, who is really helping to address some of the structural problems we were having and being able to conduct research here in Kenya. That was very unfortunate. But I think as part of us as human beings is this wonderful thing called hope. And we always hope for a better future. We know we're going to get through. Kenyans in particular, I think, are very resilient people. They've endured many difficulties. They've endured terrible political violence. They've endured years of corruption and many difficulties of many kind. But they remain inventive. They remain creative. They are vigorous, and they really want to make a difference. And I think there's also some benign sort of ignorance about the pandemic. It's like, well, it's not happening to me. I'm not seeing people die on the streets, you know. So there is this, and particularly because it's a young population, I guess. So there is a sense of, you know, we've got to get on with it. And but things are really difficult in terms of food and jobs right now. We're not seeing open hunger, though. Thank God for that. But it is a struggle. It is definitely a struggle. We keep our hope.
Thank you.
Thank you, Teo.
Thank you, Taráz, for that note of hope. And you know, we strive for and think about resilience across the globe, you know, and particularly in our younger generations. So that's what we all hope for. Happy birthday, Raz. If we were a singing group, we'd sing to you, but we're not. So we will spare you that. Welcome, Timothy. Please feel to join us in the future. Taráz, that was great. Really well done, very rich. And, you know, this whole intersection of COVID and HIV and how people are mobilizing with the experience of those of us who have worked in HIV and bringing our skills to bear in the COVID pandemic. You know, looking at health inequities across both pandemics are important for us to keep in mind. So thank you. Thank you everyone for being here. Hope to see you during World AIDS Day week for our grand rounds, also for the AIDS Institute ETE Summit. Please feel free to join that as well. And for those particularly in the US, celebrating Thanksgiving. We know it's challenging times. We know people are not having the usual gatherings that they have, but we hope that you're able to have a grateful and a healthy Thanksgiving, and gratitude to all of you for being here. So be well, take care, and we'll see you all soon.
Thank you. Bye-bye.